Belum daftar.
Kardiologis,
Kamu tahu nggak itu iklan itu? Enggak, kamu masih tahu. Kamu tahu nggak? Iya, aku cari nama masih muda. Masih muda. Gimana aku nama aku doang. Hmm? Tidur. Kreatifnya dok itu.
Thank you, Dr. Fujita, for your great topic today. It's really enlightened our mind in
What I did, I was doing OS, with it seems like we have, but then when I decide to put the stent, it has some malopposition, several malopposition, several.
Oh iya peserta
Diganti nama.
Jantina, iya.
Recording in progress.
Lima hiji teh. Hah? Ulang tahun tuh. Kali lima hiji. Dua kali.
Okay. Can. Okay. Hello. Hello, Professor Prakana. Yeah. Yeah. Okay. Okay. Thanks, Professor Prakasa introduction. Hello, everyone. Thanks your invitation. Today, I will introduce the training system of Wuhan Asia Heart Hospital, the grading operation of congenital heart disease, and some complicated congenital heart disease operation. In order to save time and place mostly, I recorded the lecture content as a video and translate with help of artificial intelligence language. If there are any inaccuracy, I hope you will understand. So should I start my slide? Can you see the slide?
Cardiac surgeon training and graded surgeries. Part 1, General Information. Approved by Hubei Provincial Department of Health, established on November 11, 1999. More than 2,000 employees, received 3.6 million patients from 33 provinces. More than 74,000 cases of cardiac surgery. Wuhan Asian Heart Hospital is the national cardiovascular disease treatment center in China, ranking third in China in terms of the number of operations for 19 consecutive years. In 2023, there were more than 8,500 operations. The Surgical Heart Center has 12 wards, 355 beds, and an ICU with more than 90 beds. It is divided into adult centers and pediatric centers. Since the establishment of the hospital, more than 70,000 operations have been performed. This is the growth of surgery in a single center, Wuhan Asian Heart Hospital. In 2023, 1,756 cases of intervention were completed in the Congenital Heart Disease Center, ranked number 1 in Hubei province and number 4 in China, and the scope of medical services radiated to the entire central China. More than 100 kinds of cardiac surgery. The age of patient ranges from 13 hours infant with complex congenital heart disease to 91 years old. Simple and complex CHD, AVP, AVR, MVP, MV or TAVP, TVR. CABG pump, off pump, great vessel operation. TAVI and all kinds of hybrid operations. Thoracoscope operation, mini maze procedure. Heart transplantation, ventricular assist. Peripheral vascular operation. From 2012 to 2022, the Intervention Center for Congenital Heart Disease and the Pulmonary Hypertension Center were established respectively. Congenital Heart Disease Center is the earliest unit in Hubei province to carry out interventional diagnosis and treatment of congenital heart disease, and is the first national interventional treatment training base for congenital heart disease in Hubei province. In 2022, the Congenital Heart Disease Center completed 1,301 cases of interventional surgery, ranking first in the province and fourth in the country, and the scope of medical services radiated to the entire central China. Main types of interventional procedures: VSD, ASD, PDA. Percutaneous valvular balloonplasty, mitral, pulmonary valve, aortic valve. Pulmonary arteriovenous fistula closure, ventricular septal perforation. Percutaneous coarctation of the aorta stenting. coronary fistula closure, atrial septal ballonostomy, complex congenital heart disease medical and surgical mosaic therapy, PTPA, pulmonary artery stenting. Part 2, Training Program. Training is mainly divided into skill training and clinical thinking training. Trainees should receive basic training and then make personalized plans according to everyone's learning embodiment. At the same time, multiple groups of teachers train a trainer. There are several important milestones in the advanced training, including residency training after graduation, chief resident training, attending surgeon training. Among them, chief resident training is an important part of surgical growth, which requires doctors with 5 years experience in cardiac surgery for 3 years, including all the basic cardiac surgery techniques, open chest and closed chest to establish cardiopulmonary bypass, and various minimally invasive cardiopulmonary bypass, cardiac assistance, and treatment of complications, including thoracoscopy and simple surgery, including the first assistant of the type A dissection. After the training, the chief resident can become a simple congenital heart disease surgeon, TOF surgeon, valve replacement surgeon, valvuloplasty surgeon, and coronary artery bypass grafting surgeon. Advanced training includes complex congenital heart surgery, aortic dissection, complex coronary artery bypass grafting, and heart transplantation. According to different diseases, the number of operations reaches 20 to 100, and the training period is more than 2 years. The indicators of training are mortality and complication rate. The training content includes the management of patients, the understanding of patients, the analysis of their condition, the judgment of surgical indications, and the choice of surgical methods. Observation after operation, operation specification, operation results, cooperation with other departments, etc. Surgical grading and partial surgical demonstration. We divide congenital heart disease surgery into 5 grades. The first level includes simple congenital heart disease, such as atrial septal defect, over 8 months old. The second level includes 3 to 8 kilograms, 3 to 8 months of age, VSD, PDA, ASD, etc., or mitral repair, MACE, complex congenital heart disease, such as PECD and other operations. The third level of simple surgery includes adult TOF, VSD with aortic regurgitation, thoracoscopic VSD surgery, and complex surgery includes TOF, PECD, TECT, IECD, etc. The fourth grade includes complete anomalous pulmonary vein drainage, aortic arch constriction, Epstein malformation, single ventricular correction, pulmonary atresia, double outlet of right ventricle, and so on. Grade 5 operations include Nikodal, Cantrell syndrome, and Ross operation. More complicated ones include double switch, single adventure, and bi-adventure correction, combined with 2 or more types of complex genetic heart disease. The training of interventional surgery begins with simple patent ductus arteriosus and atrial septal defect. First case, VSD with ruptured aortic sinus. Aneurysms patient, thoracoscopic procedure, inspect. Remove the ruptured sinus wall. Direct suture the ventricular septal defect. Remove annulus fibrosis and calcification. Patch repair ruptured aortic sinus aneurysm. closure. Second case, PECD patient. Inspect tricuspid valve. Open atrial septal. Explore mitral valve. Suture mitral valve fissure. Collapsing partial valve ring. Patch closure atrial septal defect. Third case, VSD with double chamber right ventricle. Remove the outflow tract muscle.
Recording in progress.
Patch repair the VSD. Repair the tricuspid valve. Testing. Closure. Fourth case, atrial septal defect patient. Vertical lateral thoracotomy. Harvest pericardium for patch repair. Retract right atrial appendage. Cannulation. Cross clamp. Open right atrium. Patch repair atrial septal defect. Fifth case, tetralogy of Fallot, lateral thoracotomy. Established cardiopulmonary bypass. Open right atrium. Patch repair ventricular septal defect. Testing tricuspid valve. Open right ventricular outflow tract. Test pulmonary artery. Patch enlargement. Closure, PFO. Sixth case, Cantrell syndrome with ventricular septal defect. Open chest, detached heart. Repair the left ventricle. Repair the ventricular septal defect. Repair the chest wall. Seventh case, TGA plus TECD plus TAPVC patient. Inspect. Nikaido procedure. Patch, repair the position of the original left coronary artery. Suture left coronary button. Mitral valve repair and patch repair for inflow of ventricular septal defect. Patch repaired atrial septal defect with corrected TAPVC. Patch repaired outflow ventricular septal defect. Sutured right coronary button. Patch repair TAPVC. Patch repair ventricular septal defect in right ventricular outflow tract. Reconstructed right outflow. Its case, pulmonary atresia type 3 patient. Separating the right pulmonary artery and fusing it. The left pulmonary artery was separated and fused. Connect the fused left and right pulmonary arteries. Incision of outflow tract and continuous suture of left and right pulmonary artery connection with bovine jugular vein valve pipe. Ninth case, single ventricle with TGA, double ventricle repair with switch. Switch. Open right ventricle outflow tract. Reconstructed ventricle septal. The incision of right ventricle outflow connected pulmonary artery. The 10th case, CCTGI patient, double switch. Inspect. Switch procedure. Ventricular septal defect repair. Sending procedure. Suture coronary button. Aortic valve repair. Pulmonary artery reconstruction. Aortic connection. Finish sending. Eleventh case, double outlet of right ventricle with pulmonary VSD and right ventricle outlet stenosis. Nikaido procedure. Harvest coronary button. Translocated aortic root. Repair the ventricular septal defect. Sutured coronary button. Connected aorta. Reconstructed right ventricular outflow. In order to ensure the training effect and reasonable promotion, we classify all kinds of complications and patients' conditions into 9 squares as the assessment standard for training doctors, and those who fail can pass the exam. According to the complexity of the operation and the severity of the patient, it is divided into 9 stages. There are different assessment measures at different stages. Thanks for watching. Cardiac surgeon training and graded.
We will do the best for training the young surgeon for Indonesia. Thank you. Thank you.
Good morning, the audience, dear colleague, my friends, and all of the audience. So my name is Hairul Ahmad. I am from Bandung and work at Paramarta Hospital. I am as a cardiologist, interventionist, and electrophysiologist. So I will present the topic same cases with different management. I have no disclosure. So we know that accessory pathway is a condition that there is leakage between the atrial and ventricular, and then this condition can make the electrical impulse directly can go to from the atrial to the ventricle or reverse. So manifest of accessory pathway, as we know that the WPW is a pathway that conduct anterograde to cause ventricular pre-excitation pattern on the ECG. Concealed accessory pathway, that a pathway that conduct only retrogradely and does not affect the ECG pattern during sinus rhythm. So this is the mechanism of the accessory pathway. We can see here in patient with the sinus rhythm, the electrical impulse from the SR node will go directly to the accessory pathway, and this condition there is no decremental conduction. So there is the pre-excitation first before the electrical impulse came from the AV nodule. And then from ECG, we can, there is the discernible that there is the ECG. From ECG, there is the delta wave. So in condition of the orthodromic APRT, the conduction of electrical impulse came to the AV nodule and then directly to the ventricle and back to the atrium via accessory pathway. This is the condition that I have said before. And then go directly to the case. This is the case one that Mrs. E, female, 28 years old, came to our hospital with palpitation, with history of heart failure, and from echo the ejection fraction is 25%. We can see here that in ECG there is the wide KRS complex with a slurred of QRS. And then we can see beside that the positive in lead 2, lead 3, and wait a minute, and positive in AVF, but negative in V1. So this means that the position from the ECG, the accessory pathway is the right side. The second case, Mr. S, male, 46 years old, with came to the emergency with palpitation without no history of heart failure, and from echo the ejection fraction is normal, and from coronary angiography is normal. We can see here that there is the positive delta wave in lead 2 and negative in lead 3 and positive in AVF. And we can see here that the V1 is negative. So according to this ECG, we can we can predict the localization of the accessory pathway. There is so many algorithm like Aruda and then the George and so on. We can predict the condition of the position of the accessory pathway. This is the how to manage the patient with AVRT. If there is the condition of patient is stabilized or not. If stable, so we can do the vagal maneuver first. This is the class 1B. And then if there is the unstable of hemodynamics, so we should do the cardioversion. If the condition is in chronic, so the patient symptomatic and recurrent of tachycardia, so the first choice is catheter ablation. But if the patient doesn't want to be to be done the catheter ablation, so drug therapy should be considered. And then the class 2A is we can give the diltiazem or verapamil or beta blocker. But we must know that the condition of patient, is it very good? There is no structural heart disease. And then the second, if asymptomatic pre-excitation, we can see here that is it this patient is in the high risk occupation or competitive athlete? So if the occupation is in high risk, so electrophysiology study for risk stratification is class 1 to be done in this patient. And then if high risk feature, after we perform the electrophysiology study, so we do the catheter ablation. So how about this condition? In case 1, we can see here that the ECG is the delta wave is negative in V1 and positive in lead 2, lead 3, and FEF. So this patient is should be near or uh, uh, in the FE nodal. This is the condition of patient when we will do the uh, uh, electrophysiology study. This is the RAOPU. We deploy the lead in the right ventricle, and then the his and coronary sinus, and then we can see here the electrophysiology of this patient. As we can see here that the from the his refractory pacing, we can see there is the advancement of the electrical. So we perform the stimulus from the right ventricle. We can see there is the impulse, electrical impulse goes through to the atrium with different duration between the tachycardia cycle length. And then we can see here when we do the atrial pacing in this patient, we can see that on the atrial pacing that the accessory pathway is refractory. We can see there is the narrow KRS complex in bit after we perform the second stimulus. We can see here that there is the HV is longer compared to the stimulus 740 millisecond. We can see here that in his distal, there is fusion between the atrial and ventricular. But in stimulus 630, the electrical impulse from H and V is longer. So we can see here that the KRS is narrow in S2 impulse, stimulus electrical impulse. This means that this patient have accessory pathway in his position. So for this patient in this condition, should we do the ablation or not? So if we perform the ablation in this condition, so the patient will have complication total AV block. So we need to do the pacemaker, but this condition of patient is in heart failure, so we must have a informed consent first before we do the ablation. In this is the second case that Mr. S with palpitation too, and then from echo and coronary angiogram is normal. We can see here that there is the WPW pattern, and then this is the ECG. We can see here the ECG of this patient is the near the ablation catheter is near from the his catheter. So their delta wave, unfortunately, the coronary sinus doesn't make the directly into the duodeca, doesn't deploy into the coronary sinus. We can see here that in pre-ablation, we can see that there is the concentricity of the electrical impulse. We can see the earliest is near in the his distal, and then the position of the catheter ablation is very near from the his catheter, and then we perform the ablation. And after ablation in this position, we can see here that the A and V is longer. It means that the catheter ablation is successful. So this is the ECG of the patient pre-ablation. We can see there is the WPW syndrome, and then this is the ECG post ablation, and the ECG is normal. So, as a conclusion of this presentation, we must know that understanding the variation in pathway electrophysiology is the key to understanding variation in presentation and management issues. Thank you. Good morning, the audience, dear colleague.
Thank you, Dr. Johan. Okay, ladies and gentlemen, good day. On behalf of Paramarta Cardiac Hospital, I would like to thank to all of you for your engagement and contribution throughout these enlightening webinars about update in latest heart case management. As we all know, the landscape of heart case management is evolving rapidly with significant advancement in technology, treatment protocol, and patient-centered care strategies. Today, we have watched and learned from the speakers regarding the latest management of heart case, and we hope I hope that today's events can serve as a strategic contribution to the development of healthcare services in Indonesia. As we move forward, let's commit to continuous learning and collaboration, sharing insight and experiences to improve heart health outcome. And together, we can make a significant impact in the life of our patient. In closing, I would like to express my gratitude to our esteemed speakers, Dr. Hairul Ahmad, our doctor, Prof. Tao Liang from Hong Kong, Dr. Fujita Sumoto from Sapporo, Japan, for your sharing. Again, thank you very much. And to all my dear colleagues for your active participation and insightful contribution. I hope that this webinar has provided you with valuable knowledge and practical tools enhance your capability and skill in cardiology. Thank you all once again for your participation, and I look forward to seeing how we can implement this insight in our daily practices. Best regard. Thank you again.
Okay, thank you very much, Dr. Jimmy, for the closing statement. And for your information, we are now in collaboration with Hongkong Asia Medical Group. That's why today we have the professional speaker from Hongkong Asia Medical Group. As we mentioned, Dr. Fujita and also Prof. Tao Liang as an expert from Hongkong Asia Medical Group will have joined in Paramarta as soon as possible with the plan of action in congenital heart disease management. Once again, thank you very much all for joining us today for this insightful webinar on the latest advancement in heart case management. We appreciate your engagement and the valuable discussion that took place. As we move forward, let's continue to collaborate and share knowledge to improve patient outcomes. We look forward to seeing you at our future events. Thanks again. As the closing, I want to tell you today is the 3rd anniversary of Paramarta Cardiovascular Hospital, and we are very happy if you want to share your patient or others to us. Thank you very much all. Thanks for the participation and thanks for all of our speakers. Once again, thank you very much. Good afternoon and Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam. Thank you, Dr. Glenn.